My name is Dr. Jenkins Bush. I'm an orthopedic surgeon with Resurgence Orthopedics, and I'd like to run through a video clip of a shoulder arthroscopy case with use of the IntraVu needle arthroscopy device. A few quick words about setup and indication with regards to patient selection. The video that will be introduced and played has the patient in a beach chair position. This is a commonly used technique and positioning method for shoulder arthroscopy procedures, but individuals who are more comfortable in the lateral position, it can be translated to that positioning construct as well. In this particular case, the patient is anesthetized with an IV propofol general anesthetic as administered by our Department of Anesthesia. However, the portal sites as well as the joint are injected prior to initiation of the case with 1% lidocaine plain with roughly 5 cc's in each of the portal sites potentially to be utilized and another 15 to 20 cc's within the joint. Prior to beginning the case, the joint is ranged to allow for infiltration of the local anesthetic into the soft tissues for comfort for the patient. And a fairly minimal draping is utilized to keep cost centers down for the facility at which the procedure is done. As we move forward into the video, so as mentioned, the patient is in the beach chair position. My surgical assistant, nest or scrub tech is holding the arm. Standard posterior portal is used and the joint is entered with the biceps tendon being viewed in the central portion of the imaging. There can be some challenges with synovial tissues and residual fluid in the joint on initial entrance and beginning the procedure. But here we start to clarify things a bit. Again, the anterior portion of the shoulder is in front of you with the biceps tendon crossing and the humeral head to your left. And then as we rotate the scope and infiltrate a bit of air into the joint, we clear up the field a bit, and we're able to better visualize the glenoid on the right and the humeral head on the left. As we lock the air within the joint, instilling a bit more air at this point to clear up our field, we're able to manipulate the scope without necessarily any movement of the arm to visualize a rotator cuff above us to the top left corner. And in this particular case, the patient is a 40-year-old female with known chondral lesion of the superior humeral head, which was visualized there. And we can confirm integrity of the rotator cuff without any high-grade or full-thickness rotator cuff tears. We can visualize the anterior labrum directly in front of us, as well as the posterior labrum, and the superior labrum and biceps tendon attachment. Powerful tool allowing for confirmation of interarticular integrity of structures, either de novo without the adjunct of a previous MRI, or for confirmation of findings seen on previous MRI. I use a standard anterior superior portal to insert a spinal needle within the glenohumeral joint and confirm placement within the joint. You can certainly direct the needle to the labrum or the rotator cuff depending on pathology being addressed at that time. I attach the syringe with the platelet-rich plasma. My assistant assists me in securing onto the spinal needle, and then direct the IntraVu scope to the tip of the spinal needle and inject the platelet-rich plasma layer directly into the glenohumeral joint under direct visualization, which is a very, very nice tool, not only for confirmation that your injection went exactly where you planned, but this can also be shown to the patient post-operatively. Thank you so much for your time.